This is another video on heart physiology. And this is going to be a great video. We're going to recap a lot of the things we previously talked about in our last, I think, 5 videos, all right? So let's just start from the beginning. Let's just draw the anatomy of the heart. We said your heart is a 4-chamber pump. You have your right atria and your right ventricle, your left atria and your left ventricle. And we said blood will fill the atria and then go down to your ventricles, and your ventricles will pump that out, right? Pump that out. And where do they pump it out to? Well, another way we can draw this is by breaking up the heart. So breaking up the right side, right atria, right ventricle, and bringing it up to the left side. Left atria, left ventricle. And we drew our lungs in between. Now it's a great way to remind us that your right heart pumps blood to your lungs to get oxygenated, and that goes to your left heart. Goes to your left heart to pump out to your body. And then it will return the blood, and the cycle repeats itself. The cycle repeats itself. And it goes in this direction, right? It only goes one way. And what stopped it from going the other way? Do you remember? We said valves. Valves. So you know I'm going to ask you, do you remember the names of the valves? What's the name of this valve in your right heart that stops the blood from your atria to your ventricles? Do you remember that? That's your tricuspid valve. Remember, we used to call it the right cuspid valve. That's a great way to remember. And then the valve that's regulating the amount of blood that goes to your pulmonary circulation is going to be your pulmonary valve. Pulmonary valve. Pulmonary valve. On your left heart, the valve stopping the atria, the left atria and the left ventricle, is going to be called your bicuspid or your mitral valve. And then the valve that regulates the amount of blood that goes through your aorta is going to be called the aortic valve. Aortic valve. Just some review. Now, how do your valves know when to open and close? They don't have brains, right? So how do they know when to open and close? One of the biggest ways, the biggest mechanism, is by pressure. I think of your valves as like a saloon door. You know, like those old Western films, and they have those doors that close. And you push and push and push on the valves until they swing open, all right? So they're closed, and you put pressure on it until it swings open. And then when you relieve that pressure, the valves will come back shut. Come back shut, is that even grammatically right? Will close, they'll close, okay? So one of the biggest ways to open a valve is pressure. Pressure opens a valve. Pressure opens a valve. Let's see if we can talk about how our heart pumps and opens these valves. We said initially, blood will go into the atrias. Blood will go into the atrias and fill it. So our first step is blood fills atria. Blood fills atria. And when it fills the atria, enough blood will build and build and build until it will pop open these valves. It will push open these valves. It will push open the tricuspid valve, push open the mitral valve. So our blood fills atria, pushes open tricuspid and mitral, and blood will fall into your ventricles, go into your ventricles, go into your ventricles, fill ventricles. So that's your first step. All right, 1. And as they're filling your ventricles, your atria contract. Remember, that was kind of the first thing we talked about when we talked about your heart beating, conducting. Your atria contract. And they contract because they want to push any remaining blood into your ventricles. Your heart wants to get the most bang for its buck, right? It wants to get the most blood out. So it will contract and push the remaining blood into your ventricles. So, all right. Atria contract to push remaining blood. Now your ventricles are nice and full of blood. Now your ventricles are full. Ventricles are full. And now your ventricles will contract. Your ventricles will contract. contract. And what do you think happens when they contract? Well, when they contract, the blood will push against the pulmonary valve and the aortic valve. They'll push against these valves, push, push, push until they pop the valve open. So, all right, contract and push open aortic and pulmonary valve. Now, the important thing to know about this is it takes time. Your ventricles have to contract and push, 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 push until the valves open. It's not instantaneous. They don't just contract and the valve just opens. It has to build that pressure, build that force, push that door open, push that valve open until it finally opens. So, all right, it takes time. I'm gonna put a star, I'm gonna circle it. All right, so it takes time, it's not instantaneous. How can it be? Yeah, you have to build that pressure. So it takes some time to push that valve open. Now you might be thinking, if your ventricles contract and they're pushing blood out, what's to stop it from pushing blood back up to your atria? That's a great question. You see let's just draw your right atria and your right ventricle. And there's a tricuspid valve right here, pulmonary valve right here. You have muscles in your ventricles called papillary muscles, papillary, that have these tendinous cords called chordae tendineae. That's where the name comes from. And when they contract, they'll pull on these cords and close that valve to make sure there's no backflow. And that way, the only blood that comes out is going to go through the pulmonary valve. Only go through the pulmonary valve. Very important that you know that. But that's just an aside. So your ventricles contract, push, push, push until they blow these valves open and your blood will leave your heart. Go where it needs to go. So, all right, blood leaves ventricles. Blood leaves ventricles. And now your ventricles relax. And when they relax, when there's no more pressure pushing those valves, what do your valves do? They close. All right. Aortic and pulmonary valves close. And the cycle starts all over again. Blood will return to your atria, start building until it pops open your tricuspid and your mitral valve, and then blood will drain into your ventricles. And to make sure we have every little bit of blood left, we have our little atrial contraction. So our atria contract, push the remaining blood. Now your ventricles are full of blood, and now your ventricles will contract. And push these valves until they pop open. And then all the blood will leave, your ventricles will relax, the valves will close, cycle starts all over again. That is how your heart pumps blood, and that is how your valves make sure they only go the direction that you want them to. Now, when your ventricles contract, we call that systole. That literally means contraction. And when systole occurs, when they contract, we said that it pulls your mitral and your tricuspid valves close. Pulls these close via our chordae tendineae, right? So, all right, close mitral, tricuspid. And when they pump against these closed valves and against all this pressure, it causes a lot of turbulence in the blood, and you can actually hear systole. You can actually hear the closed mitral tricuspid. You can actually hear the turbulence as a sound when you auscultate the heart. We call that sound S1. All right. Now, when your ventricles relax, we call that diastole. Diastole means to expand or come apart. Your ventricles are relaxed and they're coming apart. They're not squished and contract, they're relaxing. Diastole. And in diastole, when your ventricles relax, we said your aortic and your pulmonary valves no longer face pressure, and then they close. So aortic, pulmonary valves close. And blood will fill in, and you will hear the closure of these valves. You will hear that turbulence, blood turbulence. That's a sound, and we call that sound S2. S2. These two sounds make up the heart sounds that you hear when you auscultate the chest. The bum bum, bum bum, bum bum, bum bum. S1, S2. So S1, S2, S1, S2. That's the lub-dub heart sounds, okay? That's what causes the heart sounds. Now, let's say you have a patient and you take out your stethoscope and you say, I'm gonna listen to your chest, and you expect to hear the lub-dub, and you hear boom, 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 boom. You hear 3 heart sounds. And you freak out, you're like, what is that? What is that? That is called S3. S3. And S3 can be normal in young patients, even in pregnant patients. Right, can be normal. Can be normal. But you can also see it in patients that have fluid overload. All right, so we're talking about people that have heart failure. We'll talk about that later, where they can't pump the blood out, so their heart is full of fluid. Or you might be giving someone too much IV fluid, and now they're fluid overloaded. Anything that causes fluid overload causes it S3, fluid overload. Why does it cause this S3? Why does it cause this sound right after diastole? Well, in diastole, your heart relaxes. Your heart relaxes, and if you fill it up more than its capacity and it has to stretch, it causes more turbulence, and you can hear that turbulence, that heart sound. So you see it in fluid overload. You stretch that ventricle way more than it needs to, and you hear that heart sound in early diastole. So I'll just draw it in. Be like right here, S3. So we go boom, 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 boom. 3 heart sounds. The way I've gotten questions like this, they'll show this, or you'll listen to the heart and you'll hear this, and then they'll say in the answer choice, pick which patient would have this. So look for people that are fluid overloaded. All right, people that are fluid overloaded. Now let's say you take out your stethoscope and you listen to your chest and you hear a sound in late diastole. Late diastole. We call this S4. Late diastole. This is seen in really hypertrophied and stiff hearts, stiff ventricles. So stiff, hypertrophied ventricles. Well, what causes this? What happens in late diastole? What happens in late relaxation? We say your heart relaxes, right? And then your atria will start to fill with blood and push these valves open and start to fill your ventricles. And right before your ventricles contract, right before systole, your atria will give a little push. Try and get as much blood in as possible, right? And if you have a stiff, hypertrophied heart, when your atria contract against that stiff heart, it won't go anywhere. It'll cause a lot of turbulence. You get that S4. You get that S4. Okay? So S4. Late diastole. Again, they'll show you this diagram where you'll listen to the chest and you'll hear that late, that diastolic sound, and then they'll say, what patient will likely have this? And then you look in the answer choices, look for someone with a hypertrophied heart, someone that has cardiomyopathy, has long-standing hypertension where it has to pump against that pressure, all these stuff. We're going to talk about all that stuff later. So if you're thinking, what, we haven't talked about heart pathology, why are you getting into it now? We'll talk about that later, but just know stiff hypertrophy ventricles cause an S4 heart sound. All right, that's a lot of information, and I don't even think we're halfway done. So this is going to be a long one, folks. This is going to be a long one. So we said that in physiology, they like to confuse you with charts and graphs and diagrams, and they have a diagram. They have a diagram for how your heart pumps out blood, and we call that diagram the PV loop. pressure volume loop. Pressure volume loop. And sure enough, it looks at the pressure in your ventricles and the volume in your ventricles. And the loop kind of looks like this. The loop kind of looks like this. And we'll start right here. We'll start right here at this point. That is a good point to start. And in this point, your ventricles contract. Ventricles contract. Another way of saying ventricular contraction was systole, right? Was systole. And in systole, your heart will pump, push against these valves until they pop them open. Push against these valves until they pop them open. And also when your ventricles contract, you have your chordae tendineae that will close your mitral and tricuspid valves. So right, mitral, tricuspid, close. Can you hear that? Yeah, that's S1. So your ventricles are contracting, they're pushing against these valves. They're pushing against these valves. Pressure rises, pressure rises. Pressure rises. All right. However, no blood has come out yet. No blood has come out yet. We said it's not instantaneous. Your valves don't instantly open. So they're still pushing against these valves, but your valves haven't opened. Blood hasn't leaked yet. So this part we call isovolumetric contraction. You're contracting, you're increasing pressure, but the valves haven't opened yet. You haven't released any blood yet. Volume's the same, contraction. But eventually, you will blow open that valve. So, all right, aortic and pulmonary valve open, blood leaves. Blood leaves. And when blood leaves, your volume will decrease. Your volume will decrease. Now your ventricles have pumped out all that blood, volume decrease, and now your ventricles relax. So at this point, your ventricles relax. Another word of saying ventricular relaxation was diastole. Remember diastole? Did you have a heart sound in diastole? Hopefully you said yes, hopefully you said S2. When your ventricles relax, all that pressure drops, these valves close, and you can hear that, and the turbulence associated with that as S2. So all right, aortic, pulm, close. Aortic valve and your pulmonary valves close. Diastole, S2, all that good stuff. All that good stuff. Now when your ventricles relax, the cycle starts all over. Blood will fill the atria. Blood fill atria. Blood fill atria. So blood is filling the atria, so why isn't the volume changing? Why isn't the volume changing? Why is the volume the same? Well, blood fills the atria, but none of it goes to your ventricles just quite yet. Remember, it has to fill until it builds enough pressure to pop these valves open, pop these two valves open. And then blood can go in. So it's filling, but your volume stays the same. It's filling until finally those valves pop open. Mitral, tricuspid, open. And now that you're open, your volume can increase. Your ventricle volume can increase until eventually you start the whole cycle over again. You contract, pump that out, fill it back up. That is the pressure volume loop. Pressure volume loop. Okay? Hopefully that made more sense than it looked, because this looks really messy. Great picture will be in my notes. Pull it up on the PowerPoint and then follow me as I do this, and it should make a lot more sense. Now your pressure volume loop can change depending on cardiac output. Your pressure volume loop can change depending on cardiac output. So let's just draw the pressure volume loop out one more time. Pressure of your ventricles, volume of your ventricles. We said it looked like this. And we said it can depend on your cardiac output. What made up your cardiac output? We said this video was going to be a review video, right? You know what I'm going to ask you. What makes up your cardiac output? That'd be heart rate and stroke volume. What consists of stroke volume? Pause the video. Tell me everything you know about stroke volume. We had preload, which was a fancy way of saying filling. We had afterload, which was a fancy way of saying resistance. And then we had contractility. So these things can all affect the pressure volume loop. How does preload affect the pressure volume loop? Well, you're gonna have more volume. You're gonna have more filling, right? So you're gonna have more volume and more volume. Now it looks like this. That's it. That's it. How does afterload affect this? How does afterload affect this? Well, in afterload, you have to pump against that resistance. Let me see where my prop is. We said your heart was kind of like a water bottle, and you pump the water, pump the blood out. In afterload, there's a lot of resistance. If I put my thumb over this water bottle and I try to pump it out, that's a lot of resistance. That's a lot of pressure it has to pump against. The pressure will increase. Pressure will increase. If I try to pump that water, pump that blood out, will a lot get out? No, my thumb's over it. So you're not going to get a lot of blood out. It's going to stay in your ventricles. So after systole, you're not going to pump a lot of blood out. It's going to stay in your ventricles. So after systole, after you contract, you're still going to have a lot of volume. A lot of volume. So afterload increases pressure, and it also decreases the amount of blood you can pump out. A fancy word of saying that is increase in systolic volume. After contraction, after systole, you still have a lot of blood left in your ventricles. So that's afterload. Let's reset. Let's talk about increased contractility. Increased contractility. Again, using my prop, if this is your heart, increased contractility, I'm squeezing really hard. I'm squeezing really hard. What happens if I squeeze really hard? Well, your pressure is definitely going to increase. And are you able to get more blood out if you squeeze really hard? Yeah, you're going to get more blood out. So you're going to shoot out all that blood. You're going to shoot out all that blood. You're going to get out more blood than normal. So, all right, contractility equals increased pressure. And when you pump out all that blood, then after systole, after you contract, you're going to have very little blood left. You're going to have very little volume left. We call that decrease in systolic volume. That is contractility. That's how your cardiac output can change your pressure volume graph. There's only one more graph we're going to talk about. And this is going to be called the jugular venous pressure graph. They call it jugular venous pressure because it measures the pressure in your jugular vein. Your jugular vein drains into your right atria. Yeah, your superior vena cava and then your right atria. So this is a great graph to measure the pressure in your jugular vein and also your right atria. Your right atria. But before we talk about this, let's just go over some other things we talked about in a previous video. Let's talk about ECG really quick, and I'm going to show you why this makes sense in a second, but let's talk about ECG really quick. Let's talk about ECG. We said that your ECG usually looks like this, right? And there's your P wave, Q, R, S, T. What do your P wave represent? Wasn't that atrial depolarization and contraction? What do your QRS complex represent? Wasn't that your ventricular depolarization and your atrial relaxation? What do your T wave represent? Wasn't that your ventricular relaxation? All right. Now let's superimpose another thing we just learned. How about your S1, S2? S1 coincided with systole, ventricular contraction. Where does that show up on here? It shows up right here, right? S2 coincided with ventricular relaxation. Where does relaxation show up on here? It shows up on your T wave, right? So this one, that's two. Okay. Now let's finally talk about jugular venous pressure. Jugular venous pressure. This measures the pressure in your jugular vein and your right atrium. Measure the pressure in your jugular vein and your right atrium, and it looks kind of like this. It looks kind of like this. So you have A, C, X, V, and Y. First things first, what happens first? Blood will fill your atria, eventually pop open your valves and fill your ventricles. And then your atria will contract to get as much blood in as possible. So your atria contract. We said here, your P wave shows atria contraction. And it coincides with your A wave. A wave also shows atria contraction. You can imagine, because we're measuring the pressure in your right atria, if your atria contracts, you're gonna have a huge spike. And that's exactly what you see, the A wave spike. A for atria contraction, A for A wave. And after your atria contract, it will relax. It will relax. And blood will fill your ventricles, and now your ventricles will contract. Your ventricles will contract, and blood will pump out. And your blood usually doesn't pump back into your atria because we have these valves, right? But your atria still feels that pressure. And when it feels that pressure, you'll see another spike. So C equals ventricular contraction. C for contraction, C for the C wave. Your ventricles will contract, pump that blood out, and eventually it will relax. It will relax. And when it relaxes, when your heart relaxes, you'll see this drop. We call this the X descent. Descent. Ventricles relax. X for, so the X wave coincides with X seen in relax. Ventricles relax. So the pressure drops. Coinciding with your T wave that shows ventricular relaxation. So your ventricles relax and the cycle starts all over again. Blood will fill the atria. Blood will start to fill the atria. You'll start to see that pressure build and build as the blood fills the atria. So V is for venous filling of atria. And then finally, as your atria fill with blood, eventually these valves will pop open. These valves will pop open and that blood will leave. That blood will leave and the pressure of your atria drops. That's called the Y descent. Y stands for emptying. And that is how you measure the pressure in your jugular vein. All right. That does it for this video. That is a lot of graphs, a lot of charts. Look at my notes and just basically look at it until it makes sense. And hopefully when you get on the step, you'll be able to get all these answers right, okay? See you next time.